I'm going to be presenting a background to some research that I'm carrying out with Professor Tolley and Professor Dawley and Chiwe, essentially looking to see if we can use CFD as a clinical tool to aid clinicians in the decision-making process when we have complicated patients with retrosternal goitres compressing the airway, to help us decide whether or not to perform surgery on these patients. A little bit of background into that. Every year in the UK, we perform more than 10,000 thyroid surgeries. More than 60% of these are for goitres. A sort of big reason for performing surgery on these patients is that they come to us telling us that they're short of breath or they have difficulty breathing whilst they're lying down. Obviously, that's complicated by the fact that these patients are often old or older patients with other comorbidities that might be affecting their breathing. And so what's quite important is that at the moment we don't have a clinical tool to help aid our decision-making process. We refer to goitres as just an enlarged thyroid gland. Internationally, there's no agreed definition for retrosternal goitres, but throughout the literature it's normally referred to as a thyroid gland that extends below the sternal notch when the patient is lying supine, and that can be detected either clinically or radiologically. In the way of medical management, we don't really have too much. In areas of iodine insufficiency, we can give patients iodine replacement, which can lead to a very small reduction in the goiter size. The same with patients who are hypothyroid, we can give levothyroxine replacement for them. However, most of the patients with retrosternal goitres tend to be euthyroid, and therefore there's not very much room for that. Radioactive iodine can be used to reduce goiter size, however that's only really successful in younger patients with smaller goitres, so again, not really relevant. On the other hand, surgical management does provide definitive treatment for these patients, because then the goiter is obviously no longer present and no longer causing compression on the airway. However, it does subject the patient to huge surgical risks, and therefore that's why we've got to weigh the risks and the benefits very carefully. In terms of compressive symptoms, the patients often do complain of shortness of breath. They can have other things such as difficulty swallowing. The natural history of retrosternal goitres is equivalent to cervical goitres. In some patients, they do have rapid growth. In other patients, they can remain stable for many years. There's up to 10% of these patients can have cancer within the thyroid goiter. And although a lot of these thyroid glands do extend below the level of the sternal notch, they can often be removed through a standard cervical incision in the neck, and sternotomy is not normally required. Important to note that complications for these patients are much higher than standard thyroid surgery, and that's because of the enlarged gland. So there's an argument to say if patients are asymptomatic to just leave these thyroid glands alone and monitor them. However, we do also see young patients, and we have to consider that these thyroid glands might continue growing over the period of their life, and so we carefully make a decision with them, and it's always shared care. Proportion of these patients, up to 10%, do present having had previous surgery before, may have been in the way of a subtotal thyroidectomy or a hemithyroidectomy, which again makes things even harder because second-time surgery is more difficult and is associated with higher risks. So these patients could really benefit from us determining whether or not it is the thyroid gland indeed causing their symptoms. Another thing to consider is where patients have very significant tracheal compression, post-thyroidectomy they can develop tracheomalacia, which again complicates the picture. At the moment we do use the American Thyroid Association guidelines, which was sort of published in 2014. This just uses one dimension, so we will look at the CT scan and say, is the trachea compressed more than 35% in diameter? That's based on quite a simple retrospective study looking at a number of patients who were asked, did your positional dyspnea, meaning their shortness of breath on line flat, improve after surgery? From that questionnaire, they found that if the trachea was compressed less than 35%, there was only a 65 to 70% chance of the patient saying, yes, my symptoms improved. Whereas if it was compressed more than 35%, 95 to 98% of patients said, yes, my symptoms did improve. So as you can see, the entire world is using this as their guideline, and it's based on just one retrospective study, which was a questionnaire of patients. So when these patients present to us in clinic, we typically take quite a thorough history to elucidate if they have any symptoms from the thyroid goiter. We then go on to examine them. If we can't palpate below the gland, we then assume it's a retrosternal goiter, and they go on to have a CT scan. The CT scan is used really to assess how low the goiter goes behind the sternum for operative planning should they go on to have surgery, but also to assess the level of tracheal compression. Some units do use lung function tests to assess the patient's breathing in the preoperative workup. The use of these is debatable. There was a study in 2014 that was a retrospective study looking at the use of flow volume loops in these patients, and it was found that flow volume loops didn't significantly change the outcome, or whether or not the patient proceeded to go and have surgery. So what is the problem with using just the diameter or the smallest cross-sectional area of the trachea as an indication to then go on to have surgery? It really just oversimplifies the problem, doesn't take into account the length of compression or deviation of the trachea away from the midline, which, as we know, does have an effect on the flow of air through the trachea. Worker breathing essentially is the energy provided by the subject to inhale a given volume of air. That's normally divided into two components, the elastic and resistive, and it's the resistive component that's affected by pathology of the upper airways. Again, we can divide the resistive losses into wall shear stress and internal flow losses in terms of jet or flow separation. As you will all very aware, in vivo measurements of this are extremely tricky and invasive for the patient, so we really need something that's less invasive. So we hope that CFD can offer a tool to help determine how tracheal compression and deviation affects the resistive losses and therefore the work of breathing in these patients. It has been used in the literature, there have been plenty of studies, just to pick out two studies. Brown's et al. Showed a significant increase in resistive losses when the tracheal constriction was smaller than the glottal constriction. And Bates et al. Showed significant differences in power loss when comparing normal tracheas and tracheas where the geometry was significantly altered by goitres. As we've heard throughout the course of the day, there are some limitations with CFD, especially when using CT scans. This is a static image, and as we all know, breathing is a dynamic process. We have found, looking back through a retrospective study of CT scans, sometimes the CT scan is limited in the sense it doesn't include the glottis, it may not include the carina, and we can't justify performing CT scans purely for the study, so we're using, in some cases, scans that are not ideal. Tends to be inspiration focused. And again, one important thing is the glottis is not always in the same position. So we have CT scans of patients where the glottis is almost closed. That's clearly going to affect any CFD that we run through the glottis, as opposed to a patient who's taking deep breaths whilst having the CT scan. And it's quite hard because even though the patients are told while they're lying in the CT scan to take breaths in and out, they don't necessarily always listen or take breaths at the right time. And then another limitation is, as we've heard throughout the course of the day, accurate segmentation. So in order to run CFD, we need to take the anonymized CT scans of the patient, perform segmentation to provide us an accurate surface mesh to then go on and perform the CFD. As we know, segmentation is essentially separating out an area of interest from the background and surrounding structures, providing an accurate 3D model of the patient's trachea, which can then go on to form a mesh. It can be manual, semi-automatic, or fully automated. Manual segmentation, as we know, is extremely time-consuming, as the user has to go through slice by slice each slice of the CT scan, and often we do have more than 450 slices in a CT scan, so not practical for clinical use. Semi-automatic segmentation is significantly faster and means that we have someone with a knowledge and understanding of the anatomy to make the big picture decisions, and then the computer goes on and performs all of the tedious tasks. Fully automated segmentation at the moment is not quite as accurate as manual or semi-automatic segmentation. However, it looks like that is probably the way we're going with the huge amount of data sets that we have, and hopefully that will continue to be improved. Does that mean that I'm finished in terms of time? Okay, thank you. Just looking at image thresholding, which I'm just going to briefly talk about, whether or not we use fixed thresholds or manual thresholds. There was one interesting study by Weisheimer that used a phantom oropharynx, which they had a known volume, and then they performed CT scan of the phantom oropharynx and asked clinicians to perform segmentation using both a manual method and a fixed method. They found that with a fixed threshold, there were errors in volume of up to 11.7%, which is quite significant. whereas using interactive thresholds where the clinician would decide what the appropriate threshold was individually, the errors in volume were much less, at less than 2%. So it could point to an argument for using interactive thresholds. Lots of different thresholds are used throughout the literature. Most studies do use a fixed threshold. As you can see, there's no real consensus, and this is all for the large airways. I was going to go through a clinical case. Do I have a couple more minutes to do that? Okay. So this was a 68-year-old man with a extremely large retrosternal goitre, as you can see from the CT scans. We essentially performed segmentation and a fixed threshold of minus 200 Hounsfield units and minus 500 Hounsfield units to then perform CFD to have a look at the difference in pressure loss. As you can see from this graph here, there's a huge difference, and this is the same trick here, just using different fixed thresholds. So in summary, there hopefully is an exciting future for the use of CFD when looking at deciding to operate or not on complicated patients with retrosternal goitres. We just need to be very mindful of the fact we need to have a critical approach towards methods for segmentation and thresholding. Very happy to take any questions. Thank you.